cognitive impairment in MS is one of the most common symptoms and leading causes of disability. Depending on the study you look at, it could affect anywhere from up to like 60% of patients or even higher, depending on the exact population and what questions we're actually asking. Now, traditionally, when we talk about cognitive changes in MS, what we are really noticing is that there's an issue in what we call processing speed, meaning how quickly can you integrate information, which makes sense when we're talking about a disease such as multiple sclerosis, because it is a demyelinating disease. These signals are slowed down, so it makes sense that processing speed is a first noticeable effect of the cognitive profile of someone who's starting to have difficulties. What this manifests is MS patients will maybe have trouble multitasking. They need more time to do things, and it becomes kind of harder to integrate. That's sort of what we've always known about MS, but what's interesting that I've noticed in clinic is that when patients are coming to me and they become older, one of the most common questions as they start to have memory difficulty is this the typical memory difficulty that we'd expect from someone with MS? Is it purely a processing speed problem? Or if you're getting older and we know differently that risk of Alzheimer's increases with every decade of life, are you now also developing a potential memory disorder that has to do with the memory retrieval and storage process itself, which is more classically described as the difficulty that we see with Alzheimer's disease? So that was where our interest lies, because when I searched for information on it, there's actually not a lot of data there and nothing exists. So that's sort of the basis of our study and why we were interested in this particular question is what is the difference in cognitive profiles in an older patient with MS, and how does that compare to someone who's more classically diagnosed with Alzheimer's disease? And are there similarities that we expect? Are there differences? And that's kind of the basis of our study.
What we did was, what we were interested in doing is exactly what Lei said. We wanted to understand more about how the cognitive profiles in these two groups of people were similar or different. So what we did was we conducted a retrospective chart review of people seen for a neuropsychological evaluation at the Cleveland Clinic. And we looked specifically at people with confirmed MS and biomarker confirmed Alzheimer's disease. And what we did was, in order to look at the groups effectively, we split each one of these groups, so the people with MS and the people with biomarker confirmed AD, into either cognitively normal, mildly impaired people, or more severely impaired people who are also functionally impaired, so more like a dementia process. And we wanted to see how the profiles looked at each one of these stages, so to speak. So when you're more mildly impaired, does that look different than when you're more severely impaired? And to see whether these profiles held up over time. So we had a small group of people with MS, a small group of people with confirmed AD. And what we found was at the level of mild impairment, the groups were different, but in a way that we didn't expect. So they were different actually on tests of memory, not on tests of processing speed or attention, which are typically those hallmark detriments among people with MS. And when we then looked at the next group, so the people who had more severe impairment that's more impairing and really affects quality of life, again, we found more similarities than differences. And actually, once we got to this level of impairment, there really were very few differences at all. But again, it was on a memory test, not processing speed or attention or some of those other skills that we would consider to be most commonly impaired among people with MS. So when we looked at the overall profiles, what does it look like? So typically MS can have a lot of subcortical impairments, which Lei mentioned: the speed, attention, the learning aspects of memory, versus Alzheimer's disease, which tends to have a more cortical profile with semantic fluency and memory impairments, more episodic memory impairments that are related to consolidation and retrieval. So what we found was we saw those typical patterns emerging when people were mildly impaired by the disease process. But once more severe impairment was present, those patterns disappeared. And people in the two groups looked very, very similar to each other. And so, one of our conclusions was that this profile analysis that is so classically done in clinical settings to try to help us determine the cause of cognitive impairment may be less reliable for older people with MS than it is for other groups of people. And I think we have a lot more work to do in this regard so that we can try to better identify the sources of cognitive impairment for people with MS, because that's going to help us find proper treatments, especially in this age of new AD medications. It's even more important now, but also to potentially down the road be able to find preventative measures that we can start early on. Our findings do challenge what we always thought, which was that MS is this subcortical process affecting mostly processing speed, attention, and learning phases of memory, that it goes far beyond that potentially. Of course, there are limitations to our study, which may make our findings not applicable to every single subgroup of people with MS. But we do think that potentially this profile is very, very different. And so we need to look into that more so that we can understand it better.
Yeah, and as Laura said, what's interesting in how this challenges our thinking is really, what do we offer patients? What do we tell them when they come to us? If I've always been traditionally taught that their only issue should be with processing speed and multitasking, I might treat them differently. And yet, if I understand that their cognitive profile is actually more of memory retrieval, consolidation of memories, that approach has to be different. And it's not something that we're offering because we haven't factored in what those memory profile changes are with age. We're kind of using the bulk of our knowledge, which is in a much younger subset, and applying it to age extremes. And I think we're realizing that as the disease changes, obviously our understanding of the diseases and the symptoms must manifest accordingly as well. And therefore, our study just really highlights what we knew. We actually were surprised too. We kind of went with our training of, this is the expected findings, let's prove it. And we're like, oh, this finding is unexpected. We kind of proved something different. So we definitely want further studies to confirm our findings, different populations, larger populations, and then looking at from a more longitudinal standpoint of if we follow someone over time, what that looks like and get better traction. Of course, this is a retrospective study, and it's cross-sectional, meaning at single time points, which doesn't give us that long-term trajectory, which we're really highlighting. But again, this challenges what was previously known, and therefore gives us that foundation that these types of studies are absolutely needed.
Yeah, and I think too, we didn't talk about this yet, but people with MS are living much longer lives now than 20 years ago or 30 years ago. Our treatments are better. People are healthier and having a longer course of disease. And so what happens after decades of living with MS and maybe experiencing neurodegeneration over that time?
I think to Laura's point is that we're finally in that stage where our patients are living long. We've actually had disease-modifying therapies. So for so long, our focus in MS care has been, let's stop relapses to stop disability. And it's been wonderful. We're actually achieving that, right? We're stopping relapses and patients are living longer. The bulk and the peak prevalence of MS is actually shifting. So it was always a younger population that had the most MS. And we're seeing that over time, that shift increases, right? So the most common age group now, or the highest age group with MS, is actually getting into that 50 to 60 year time frame. They're living with their diseases longer, plus they've been on treatment longer. So now our questions are changing and reflective of the times of what we're doing. And we're actually at that age or that time point where age is actually becoming a bigger factor. And I think it's always been something that I've recognized. I've always focused on how do we treat patients differently based off of the stages of their disease, and it's growing in popularity. You're going to see a lot more articles and research in the role of aging in diseases such as multiple sclerosis, because it becomes really critical, and it's reality. It's what we're seeing in clinic, and therefore research is always going to react and answer questions that we are facing. And if there's no answers, then we actually have to find those answers.